Welcome to Operative IQ's Wisdom Webinar Series. We hope the information and experience shared by our speaker will help you improve processes and take your organization to the next level. I'm Lisa Rainey, Director of Business Development, and our team is so pleased to be able to provide you with some great narcotics tracking information. Today's presentation will give you a glimpse into the narcotics investigation process with the DEA and FBI, where you'll learn signs to look for and steps you can take to protect your organization and your providers. Next slide, please. Before we begin the webinar, we have a few housekeeping tips to help you get the most out of your time with us. All lines are muted to reduce noise feedback, but we would love for you to use the question feature in your GoToWebinar control panel to submit your questions as they arise. After the presentation, we'll have time for Q&A, where we will address as many of your questions as possible. A recording of today's webinar will be emailed to all participants, and we'd love to hear your thoughts and feedback, so please complete the brief survey at the end of the webinar. Next slide, please. I will be moderating today's webinar and compiling your questions for the Q&A portion after the presentation, and I'm excited to introduce you to your presenter, Michael Gilbert. Michael is the EMS System Coordinator for Memorial Hospital and the Southwestern Illinois EMS system that provides medical oversight for 10 ambulance services. Michael started with Memorial Hospital in 2011, where he walked into an active narcotics investigation that required him to work with the DEA for over 4 years to conviction. A paramedic had been diverting controlled substances for personal use for over 2 years, and Michael had to go back through almost 5 years of records to compile the data into spreadsheets for analysis. As part of their mediation plan with the DEA, Memorial Hospital opted to implement an electronic tracking system, and they chose Operative IQ narcotics tracking in March of 2016. Michael will discuss how the diversion was identified, what steps were taken after it was detected, documentation that was required, and lessons learned while navigating an investigation with federal agents. And with that, it is now my pleasure to turn you over to Michael Gilbert.
Good afternoon, everybody. Like Lisa said, my name is Michael Gilbert. I am the EMS System Coordinator for the Southwestern Illinois EMS System. I've been a paramedic for the last 19 years. I've been involved in EMS for 25 now. 6 years ago, I started this position as EMS System Coordinator, managing 10 transport ambulance services, 25 non-transports. So in the 1970s, Memorial Hospital was designated by the Illinois Department of Public Health as a resource hospital. And in Illinois, the resource hospitals provide the oversight for the EMS medical director, and also issue the narcotics to the transport or to the ALS agencies. Again, we have 10 ambulance services that do transport, 25 non-transports. We run 7 dispatch agencies, and then we average about 75,000 patient contacts a year. As a resource hospital, we manage the pharmacy and the medications and narcotics going to the agencies. We provide the medical direction for oversight. The agency's responsibilities are to follow policies that are passed down from the Illinois Department of Public Health and the resource hospital, and to coordinate all their operational aspects with us. So 6 years ago, I came into this position, and on my second day on the job, I was in the office after orientation, and they were like, "Welcome to the team. By the way, you have a narcotic investigation on a diversion that we need you to look at." My predecessor was literally leaving 3 days later, so it was mine to deal with. So we started our investigation. We started looking at crew patterns, looking for the vials that we found that were diverted and tampered with, looking to see if there was a similar pattern to crew assignments, and we couldn't see anything. We looked for abnormal use, high usage, high waist, and we still couldn't see anything. Look for abnormal situations. We couldn't find anything that showed us a pattern of where this could be tied back to. At that point, we went into our first steps of remediation. We looked at numbered tags. So every narcotic box was individually tagged with a serialized number. Every time the box was signed out, the box was opened, it was inventoried, and a new seal number put on it. Each box had individual logs. Each truck had individual sign-out logs. And then each agency had logs for their safes. Every time they opened their narcotics safe in the agency's headquarters, they had to log who got in there, how long it had been open. Very similar to what the military uses for information that is confidential. So again, our tagging system was a very simple system. We just got serialized numbers on the tags, and we just tracked every time the box was opened. And then about 2 months later, after we wound up putting fentanyl back on the trucks, we had another diversion. So, and it took a very keen eye from our pharmacy, because all of our narcotics at that point was being turned into our pharmacy to be restocked back out every time they needed new narcotics. And what they found was 2 very small pinholes that almost looked like it was a manufacturer defect. As we looked into it more, we found out that it was actually tampering, and a hole was drilled through the lid and punctured, and the fentanyl was actually taken out. Lab results on these 2 vials came back that it was less than 1 microgram of fentanyl in that whole container. So agency investigation started. We started looking at the tampered vials. It pointed us to one agency. So we started looking at the accountability of the agency. We started looking at usage of that agency. Still wasn't seeing anything. Our medical director, EMS medical director at that point, pulled the owners in. We sat down with them, started having them look at things. It really, at this point, there was so much tension in this that it turned into a lawyer talking to a lawyer. The agency at this point got federal law enforcement involved. They went through a local narcotic officer in the town that their headquarters is in. They reached out to the FBI, and the FBI got involved in this. We had not known that at that point. At this point, for accountability, we were asking the agency to take ownership of this. We required them to start drug testing. Their drug testing started with people that had easy access, unvetted access to narcotics across the company wide. Supervisors, mechanics, supply folks. They started drug testing these folks in a process. It was a very expensive process, as they had to go hair follicle testing, as fentanyl doesn't have a very long half-life. So everybody had to have hair follicle tests done. That turned out to not be a very inexpensive way to go. It was very costly for them. We eventually got to the point when we had a positive drug test come back, that we started getting some teamwork with them. During this process, we looked at documentation, and our documentation at this point started out was all handwritten logs. The hospital had part of what we needed, and then the agency had the other half of what we needed, and nothing was correlated back and forth. So we slowly went through the process. It took me about 3 months to take every handwritten log the agency had for 3 years and build it into a spreadsheet. At that point, my office, with the help of my director and my administrative director and a couple other folks, we were able to pull out, knowing who we were looking at, some data. You can see in this slide, the chart to the right, paramedic X is just one of the paramedics that works for this agency. John Doe is the paramedic that was diverting. What we saw was, as you can see in this chart, is John Doe either used everything or he wasted everything. He never had a partial usage and waste the rest of what was left. It was either all or none. And when compared to his peers at the same company, we didn't see the same pattern. If you look at the graphic to the left, what that's showing is for John Doe, he turned out to have a standard deviation of 4.3 above the standard medic in his company. This John Doe was a supervisor that worked in an office and ran once in a while, and he was still 4.3 standard deviations above a street medic that was working a minimum of 52 hours a week on a truck taking care of patients. So we had this data, but it took us almost 3.5, 4 months to compile the data so we could see this type of information, which again was an eye opener for us, and something that our administrative director for the EMS system looked at and said, we have to get to a point that we can look at this stuff in real time. So like I said a minute ago, this was a manual process. This is a sample of our form that we used. Again, I had to go line by line and build this into a spreadsheet. What information I could not make out, I had to leave a question mark in that block, and I had to go back and scour through patient care reports to fill in the rest of the information. The picture in the top right hand or top left hand corner is our new process with Operative IQ. That is our form that our medics use for filling out when they do have a narcotic administration. So now we go from the handwritten chicken scratch that you see on the lower right corner form to a physically typed out document that follows that narcotic from the time our pharmacy puts it into our system to the time it goes to the grave, whether it's being used or whether it's being destroyed because it's expired. When our medical director issued a letter to the agency opening a formal investigation, we went down to serve the letter to the president of the company, and at that point we were told that they had already been in contact with the FBI regarding the theft and diversion of narcotics, and we've had our first meeting with the FBI regarding this case that day. They came in and met with us at the ambulance services headquarters, and we discussed how the process would be going forward now that we had been met with them and we were working with them. The DEA was notified by our pharmacy as is required, but they really did not get involved in the investigation until the Department of Justice asked them to come get involved. The federal agencies that we worked with over a 3.5-year process was the Federal Bureau of Investigations. They were the lead investigative team on this case. The DEA came in and met with us one day after the Department of Justice asked them to, and then we worked with 2 assistant U.S. attorneys for the process of this process until we got to trial and got a conviction. So our next steps in our investigation was after the return of the positive drug test, we immediately the medical director immediately issued a license suspension and forwarded that to the Illinois Department of Public Health, the Bureau of EMS. We then, within 9 months of that drug test coming back positive, John Doe had a warrant for his arrest that was issued out from the grand jury, charging, indicting him on 37 federal charges. 3.5 years of going through the data, filtering through data. The FBI would take the data, come back to us and say, okay, now we need to look at this. We worked with them for 3.5 years on this, and the last 30 to 60 days, I worked out of the Department of Justice office with the Assistant U.S. attorneys nonstop every day, building the data and building the reports out that they needed to for when we went to trial with this. At the end, John Doe was convicted of 37 federal charges. None of them were, none of those charges had anything to do with the theft of narcotics that he'd actually done, because the cost of the narcotics was so minimal. Ultimately, the majority of the charges were altering a federal document, which was our narcotic tracking forms that we were using, our handwritten forms. By altering those and with misinformation, they charged it with altering a federal document in order to cause to interfere with a federal investigation on the diversion. And then he was also charged with 2 counts of aggravated identity theft for putting a physician's name that gave him an order that truly didn't do it. And then the last charge was tampering with a consumer product. So we went through a week-long trial, came back with 37 convictions on all charges that we asked for. Went to sentencing. Department of Justice asked for a 10-year sentence on this, and was issued a 9-year, 7-month sentence for all 37 charges. Organizationally, our next steps was the administrative director was looking at operative IQ in conjunction with using UCAPIT vending solution as a way to track dispensing of narcotics and also tracking handling of narcotics. So prior to this, our pharmacy was handling all of the dispensing of narcotics face to face, and they would issue a box and take a box in. So it was a 1-for-1 swap. They bring a used box in and trade it out for a stocked, ready to go narcotic box. What this did was operative IQ has allowed us for better record keeping, better accountability. We have the ability to track every person that has touched the narcotics, from the pharmacy receiving it into operative IQ to the pharmacy techs taking it from the safe in the pharmacy to bringing it to the UCAPIT dispensing machine, to the paramedic dispensing it out of UCAPIT, and then assigning it to their narcotic box. And even from there, when they sign them back in, they sign them back into a safe at their agency, and then so that the next paramedic can sign them out. We created in our policy, we recommended drug testing. We ran into a legal concern that we could not mandate drug testing as a medical oversight, as we had to work around union contracts and could not force a violation of their contract if their contract had anything to do with how often they got drug tested. And then we start having more communication with our agencies at the management level as far as narcotic usage, and tying that picture back in, because we now have a document that shows us each usage, and it tells us what PCR, what patient care report it's tied to. So we have a nice dotted line to tie everything together. And so we now, as we look at the new data, as we see people with high usage or abnormal, what we think is abnormal usage, we now communicate that back down to the management of each agency, and have them do random audits, and have them do audits on the usage by that individual, so that we can verify that we're not having an issue. With Operative IQ, we did require it for all services that carry narcotics. So all 10 of our transport services are required to be using it. And then also we have one non-transport that is required to use it because they run at an ALS level. Initially, some of the resistance we met was with some of our services that are larger, our 2 larger services. It was an investment for them to have to put fingerprint scanners on every ambulance, so that the paramedics could document and sign for their narcotics at the truck, and not have to go back to a headquarters or somewhere. So there was a little resistance there. We also met some resistance with our paramedics. Getting them into the habit of, you come on shift, you sign them out in Operative IQ, where they would maybe wait an hour or 2 and sign them out on paper before. Now we are tracking that they sign them out at the beginning of their shift, so that we know they physically looked at them at the beginning of their shift. Some of the lessons that we did learn with Operative IQ after we launched it was we initially left the witness as being a open source, so that the nurses in our ERs could witness narcotic wasting. And we found out that individuals were using that as a bypass from having to get their partner to come witness when they did narcotic counts, and when they were wasting, or when they were signing stuff in and out. So we had to go back and lock down the witness side, and make all of our EMTs registered users of Operative IQ without having access to the narcotic safes and the narcotics. But they were able to, now they are registered users, and their fingerprints are registered in the system, so that we know that they're using their partners as witnesses. So again, we got better accountability now that we've rolled out this program. We're getting data in, we're getting good data. We're using the control tags. So each narcotic has its own control tag with its own control number. So each individual narcotic is labeled as its own, and and that allows us to track it from the time it was dispensed into the system to the time it was either used or it was returned as an expired narcotic. We are still using narcotic safe logs, so that we know who gets into the safe anytime they get into it. Even with our vending system, we log who gets into it every single time the pharmacy techs open that door. We do random audits. Again, if we see something abnormal, so I get daily reports on usage. If I'm seeing something that doesn't look right to me, I go work with the agency, and we do random audits on usage. By policy now, we do quarterly audits, which is automated. The Operative IQ automatically emails me the report I need every quarter, and it allows me to look at the data. It allows me to look at standard deviations. It has been a wealth of information. So this is this is a picture of what my quarterly audit looks like. This is a running look at 5 years worth of narcotics. We're not at 5 years with operative IQ, but we are only going back 5 years looking at usage of narcotics and looking at how they compare to everybody. So, and you can see on the right far side, we have someone that is way higher than everybody else. And every quarter, that individual gets audited by the agency and myself, and we look at their usage to make sure it's appropriate. Again, if we're able to explain the usage, that's something that's what we're looking for. A perfect example is just yesterday, we had a medic that we dispensed 148 milligrams of morphine to at one time. But it's when that comes back in our next quarterly report, it's explainable because the medic was doing a transport from here to another state, 4 states away, and was administering morphine every hour during that transport. So we had to upload him with enough narcotics to get through that transport. So again, as long as he's going to show up on our dispensing log as having the highest number of dispensed, and he's going to show up on our administration log as being probably the highest paramedic that has administered narcotics. But again, we can justify it because we know about the trip. When we look at our dispensing logs, usually my 2 larger services, their supervisors that handle narcotics are my high dispensing, because they're restocking all their backup trucks. They're taking care of all the backup trucks that don't have medics on it every day. But this is just a glimpse of the amount of data that we're able to pull out of operative IQ within a couple seconds now. So kind of summing it up, one thing that I would really like to stress is know your employees. The frontline supervisors really need to know their paramedics. What we found in hindsight as we were digging through data was we were able to track John Doe's theft and diversion back to an injury. And multiple members of management in the company that he worked for said it multiple times. Why did we not see this? It makes sense. It makes sense that this is when it started. The paramedic had a neck injury, and about the time the neck injury happened is when the diversion started, and the diversion and theft started happening. You've got to be able to track narcotic usage and dispensing in real time. Firsthand experience, trying to go back and do it by hand from handwritten logs, you're not going to catch a diversion without having real-time data. And looking at it in real time versus post-incident, it allows you to capture that data and see problems rather than having an incident and having to go back and deal with DEA, deal with plans on how to prevent it in the future. And then again, looking at provider education. If we look at most of the diversions in healthcare alone, most of these tie back to some type of injury or where they were treated appropriately for pain management and they got addicted and they were taken off of narcotics. And because they're in the healthcare field, they have easy access to narcotics. Or it's an injury that wasn't treated appropriately and they they go back and have easy access to narcotics. I've done a lot of research and several education pieces on pain management, and there's a lot of research out there that discusses this. And even so, because our healthcare providers, our paramedics have easy access to narcotics, it's easy for them to go that way. Where we have other folks that have poor pain management done, and they don't have easy access, and they go to illicit drugs. It's just that we have easy access, and we've got to provide education to our crew, to our staff, and to our paramedics to make them understand that there's other resources out there. And that's all I have. My email address, if you guys have questions, more than happy to work with you guys and answer any questions you guys have.
Thank you so much, Michael. We are now going to open the floor to attendee questions. So if you have not already done so, please use the question tab in your GoToWebinar panel. So we have a bunch of questions queued up that we'll go ahead and get started with. So Michael, what is the process that you followed in communicating to John Doe that he was under investigation, and what steps were taken, and how was that communication handled?
So initially, he knew he was under investigation as the employer brought him in after the positive drug test. They immediately suspended him and notified him that they were turning the information over to the resource hospital and to the EMS medical director. At that point, we sent him it's required by law in Illinois. As part of our suspension, we sent him a certified letter outlining the rules and the law and the regulations on the suspension, and giving him also the information on how to request a hearing to dispute it.
Gotcha. And can you clarify the basis of the charge of altering a federal document? Is the narcotics usage or control form or logbook considered to be a federal document in this instance?
That is what the Department of Justice explained to me. So it was altering the document to prevent the DEA from being able to track the narcotic use. It was the altering with false information, falsifying the document is what the charge was actually.
Gotcha. Falsifying what happened in that transaction, what was administered versus wasted, and so on.
Correct.
Okay, great. And then with the tools used to identify the diversion, what tool did you use for the report under audits, just before summing it up when you were showing the reports on your slides?
So the one that I'm using currently is Excel. The operative IQ allows me to pull the data out in an Excel spreadsheet, and then I have built the tabs out, and I've built pivot charts out with slicers that allow me to sort by quarter, by year, by paramedic, by drug. So I'm using Excel, and I'm just using pivot charts and slicers to do all that.
Gotcha. And from the beginning of using this program until now, have you had any other diversions or suspected diversions?
We have not. Again, the only thing that we have had is we have one paramedic that stands out above everybody else on usage, and that paramedic they get flagged every quarter. Every quarter that we do our report, they get flagged, and we do a review of their charts to ensure that all the usage that they're documenting is appropriate.
Gotcha. So it sounds like you have seen discrepancies along the way, but none that have led to further investigation where reasoning hasn't come into play. Does that sound right?
Correct. And when we looked at John Doe, when we dug into John Doe's usage, what we found was because of his management level access to their PCR, he not only was he changing the handwritten documents, but at first he was actually going back and changing other people's PCRs, their patient care reports, to show narcotic administration had happened. What we saw was as he got more and more comfortable doing it, he just quit doing that altogether. And he
Yikes.
just so
Wow. So, and that's really crazy. Did you find that employees' awareness of narcotic usage monitoring influenced their willingness to administer the meds? Did some people perhaps withhold meds from their patients in order to avoid, hitting your radar?
no. What we did find though was initially paramedics didn't want to hassle with operative IQ with the steps of using operative IQ, so they would not administer because they felt it was burnt. They didn't want to be bothered with having to do all the steps to document their narcotics. Again, as we've audited and looked at stuff, the managers of the agencies have kind of tackled that and brought it back to the EMS medical director. So we've kind of hit that with, you still have to treat your patient appropriately. And if you're not doing appropriate pain management, then that's going to be just as bad for you as not doing your narcotic tracking. So.
Gotcha. So have they kind of settled into, okay, this is the process we're gonna use, even if it's a tool that we weren't using before? Has everybody kind of settled into that's the way we're doing it now?
They have, and I think some of it helped that we're a very small, we're a very tight knit system. Everybody knows everybody, and I've done a bunch of education, very similar to what we did today, but talking more on why why we're doing this and how it protects the paramedic versus and made them more comfortable and understanding that I probably need to do this as a protection to me, not a protection to my company or the system.
That's such an important point. I think to not only protect the agencies or the hospital system that's providing medical oversight, but to protect your providers so that they don't come under question or under fire unnecessarily. I think it is in their best interest to have a system in place that protects them.
Well, and we've had a couple discrepancies where a control number was missing or they had the wrong control number, and the medics have learned very quickly that, well, I documented everything. Here's everything that I did, and they've learned very quickly that it protects them if they do it correctly.
Right, absolutely. So for providers who would be deemed as more quote unquote generous in treating pain, how do you identify more therapeutic use versus rather than diversion?
So again, that's my one medic that has the high usage. What we are doing is we audit the reports to make sure to look at we look at her patient at the medic's patient care reports to ensure that what management she's doing is appropriate for the patient. And then we also ensure that that medic's partner is also, we talk with them and make sure that they're verifying what's being wasted. So we try to close that loop as much as we can and make sure we're educating appropriately.
Absolutely. So back to your case, your diversion process. What did the investigation look like when the federal agencies? What specific documentation were they requesting as you were pulling all that together?
So initially they pulled all of our narcotic report, our handwritten logs. They took they went back 5 years. They took everything for 5 years. They took every single patient care report for 5 years. That was the initial start, and then they took my spreadsheet that kind of when we went down to the service, I had started my spreadsheet and was making notes on everything that we found on every patient care report, whether it was good, whether John Doe went back in and documented 6 months later that narcotics were given. We had that all documented on a spreadsheet, so they took that spreadsheet. When it came back to John Doe documenting that a physician gave him orders, we had to go back and pull those radio reports from 3 years earlier and turn those reports in. We also have our handwritten call logs that our nurses do at the control point. They took those for those calls for any patient that we had a discrepancy that did wound up not getting narcotics, but he documented that narcotics were given. We had to turn over all those handwritten logs along with the radio reports.
Gotcha. And another question that came in is, did the diversion stop suddenly after John Doe was suspended, further confirming your suspicions? And do you have an approximate amount of how much was actually diverted?
Yes, the diversion stopped as soon as he was suspended and he no longer had access. We honestly can't tell you how much because unfortunately, so our prior processes was when our paramedics brought the box back in and they to restock their narcotics, the pharmacy took that box and would refill it and issue it out at a later date. We can't prove it. We don't know, but we don't know if any of the vials that he tampered with actually went back out and was used to treat a patient. So there's a very strong possibility that a patient may have been treated with saline versus fentanyl.
And we'll probably just never know on some of those things.
The FBI we had a couple reports that medics had told the FBI, I gave this patient 100 of fentanyl and it didn't touch him, but I gave him 2 milligrams of morphine and it worked on and it calmed his pain down. But but there was no way to test. I mean, we're talking a year and a half, 2 years later. There was no way to go back and test and see. I mean, they went as far as looking at going back to the trauma centers that the patients had been transferred to and seeing if they had done any type of drug testing on them. And we couldn't prove anything.
Wow. So what actually caused the initial investigation that got you doing all this digging and brought this case about?
It was a pinhole in a fentanyl vial.
Okay. The picture that you showed us, it was that small?
Yes. It was just big enough for a insulin needle to go through.
That is amazing. So with the processes that you've put in place, these are some operative IQ questions for you. Are you using personal cell phones with your operative IQ application to do your narcotics changeovers on the trucks, or are you still using scanners? If I don't have that question correct, please feel free to ask again, but I'll let you finish that one.
So we're not using cell phones for our narcotic tracking. We are still using fingerprint scanners. The only thing that we did run into is we have a handful of a handful of our EMTs that are witnessing that their fingerprints just don't work. A couple of them are ladies that have done hair care for many years, and we're guessing that the chemicals they use has worn down the ridges on their fingerprints, where the fingerprint scanner won't pick it up. Operative IQ is rolled out about the time this all started happening. Operative IQ rolled out an option that allows us to do dual verification. So these individuals are now using a username, a password, and a PIN number instead of a fingerprint.
Gotcha. And that's a good point to bring up. The biometric fingerprint scanner is one of many options, one including an on-screen or touchscreen signature and password or PIN, a PIN and password, and their login credentials. So there are a variety of ways with your biometric fingerprint scanner method that you're using. Let's see, is the scanner tied to Operative IQ or another tracking system? So I can answer that one. That is one of the optional methods for verifying a transaction. And the other question is, do you have to use the biometric fingerprint scanner? So the Operative IQ answer may be no, but your thoughts on the value of using the biometric fingerprint scanner in your organization, Michael?
So we are using the fingerprint scanner because there is, even with using the dual verification, there is still a chance for a EMT or for a paramedic to get someone else's password and PIN and be able to falsify documentation by saying you have to use your fingerprint. It's a little harder to get that away from someone than a username, password, and PIN number.
Gotcha. Absolutely. So you brought up a good point with dual verification. So obviously that's not a piece that's needed in regular inventory transactions, but with narcotics tracking, you have the option to do single or dual verification. You mentioned that the witness option that you chose is to limit to only known Operative IQ users. Can you explain a little bit why you chose to do that and what the options look and feel like?
So we initially, when we rolled Operative IQ out, we did not do that. We did that about 3 months in, as we had a paramedic that was using another finger other than the one that was registered in Operative IQ as their partner to witness. It allowed so rather than bothering his partner, telling his partner to come over and do his narcotic check with him, he was just falsifying documentation.
Isn't that interesting that the reasoning for that could be simple enough, but where there's a will, there's a way sometimes.
Yeah, so at that point, we made the option to lock it back down so that we could prevent that.
That's a great point. So you can absolutely, from the system's perspective, you can absolutely allow a non-Operative IQ registered user to witness transactions. But to Michael's point, you lose that little bit of extra control in the verification process. It would be like a signature on a logbook, but to his point, you could anyone could
There's a way
be that
around
extra
it.
witness. Absolutely. All right, cool. So then there's a follow-up question on your fingerprint scanners, and it sounds like one of these folks are doing truck checkouts with Operative IQ, and they thought it would be an easy transition to use fingerprint scanners, or for barcode. I'm not sure if it was barcode scanning or fingerprint scanning. So the follow-up question was, I asked, and this was the biometric fingerprint. I asked because we're using the app to do our truck checkouts with Operative IQ. It would be an easy transition. So any thoughts on that one?
I'm not sure because I'm not familiar with the truck check side of it.
Gotcha.
I'm just starting to learn a little bit more of that because one of my larger agencies is actually talking with Operative IQ now about going to the truck check and the truck maintenance side, the fleet management side of Operative IQ because he's looking for a one solution, and we can tie that into his narcotic tracking very simply.
Very nice. Yep. And Sean, asking that question, we can be happy to get your account manager to reach out if there's any additional support we can offer you on that. The other question was, what hardware do you use for fingerprint? Is that connected to a PC or part of it? There are two authorized biometric fingerprint scanners that are provided by Operative IQ that work very seamlessly. Do you have any other thoughts on hardware from your perspective, Michael?
No, I mean, we're using the standard fingerprint scanner that you guys offered to us. This is actually the first I heard there was two. I only knew of one.
I think the other one has been within the year,
Okay.
and the second option.
I know when we rolled out, we were talking with you guys about a more slimline fingerprint scanner because the initial one that we rolled out with is kind of bulky, and to be moving it to keep moving it around on a truck, some of our services had asked for a more slimline version.
That's a great point. And this one is a little bit flatter. And the follow-up question from this attendee is, for your agency, does that work in the street or only back at the station?
So ours works in the streets because we require, as part of our equipment list as a system, we require that the trucks have a fingerprint scanner on the truck. So every truck has to be carrying one.
Gotcha. And on the hardware line of questioning, what brand or type of ID tags are you using on your medication vials?
So the ID vials or the ID tags that we're using are actually from Operative IQ. So when you receive your narcotics into Operative IQ in the program, it assigns you put your information in as far as your lot numbers and all that. And then it assigns a number based on what you've started. So you tell it, you give it the label name, and then it will start with whatever number you tell it to, and it'll just keep building those numbers out. And then it prints it out on a flag sticker that you can put on your narcotic.
Absolutely. And those can be reprinted at any time if they were ever damaged. Correct. Or ripped Correct. Off or smudged or anything.
And I'll mention, so what we've done here at our hospital is when my pharmacy tags the narcotic, they tag it, their tags are one color, and then if I have to relabel something because the tag came off, it's a separate color so they know it came out of my office.
That's a great tip, because we do have a variety of colors. Some folks like to use the variety of colors based on the substance itself. Some like to use it based on the stations that it's being used at. That's another great method to say, hey, if it comes from the pharmacy, it's this color. If it comes from, myself at the administrative side, it's this color. That's a great idea. So how do you get around the witness issue if the medication was given en route or en route and the partner was driving? Was there any pushback from EMTs on this piece?
There wasn't, because at that point we were doing the same type of witnessing on paper. The only pushback that we've had with that has actually been from the nurses saying, I didn't watch you push this. I don't know that that's what's in that vial. But their partners have not really pushed back on that.
And that's a really good point. This is just the documentation of what was done, which is probably not necessary at the time of administration or patient care. It's more when you would normally log your EPCR or documentation. So yes, when someone's driving, not a good time to bother them for a verification. So the next question, does your system or state require a double lock storage system on the ambulance? And if so, how do you accomplish this?
Yes. I believe the state does require a double lock system. What they do, so most of our services, they will put a narcotic safe inside a cabinet, and then they will lock that cabinet too. So the safe locks, and then the cabinet locks inside the back of the truck.
Perfect. And as we wrap up, because we are running tight on time, this last question is regarding documents or resources that perhaps you might be willing to share, Michael. Can you provide your spreadsheets without the data in them to allow us to see how you pull that data? Is that something perhaps we could share with attendees?
Yeah, if I pull the data out, it will it'll nullify the pivot charts. But what I can do is I can change the context. I can pull the information out and the identifiable information. I think I can share that with you, Lisa, where it may just be paramedic 1, 2, 3, 4, 5, and it will still kind of show you guys. I'll just change the names of the services and the paramedics.
Sure, that would be great. And if you're willing to do that, I am happy to share that to all attendees. So give us just a little bit of time to allow Michael to scrub that data and kind of make the information or the data in it benign, and we'll get a follow-up email out to you all shortly. Michael, if you wouldn't mind switching to, let's grab one other question and then we'll wrap it up. So I'll give everybody
Lisa, and that spreadsheet may take a little bit longer because as of tomorrow, I'll be traveling for the next week. So unless I can get it done in the hotel room, it may be a week out before I can get it done.
Good point. So for everyone on the webinar, know that you will be receiving a video recording of today's session. We also have a few handouts that are more operative IQ focused on this meeting, but within the next, I would say 2 to 3 weeks, we'll send you that information provided by Michael Gilbert via a follow-up email. So thank you for giving us some time frame on that, Michael, and I hope you have safe travels. This last question that came through before we wrap up is, what are the providers wasting substances into? Is it a designated container or just the sharps container?
So if they're doing it in the truck, they are doing it probably into a sharps container. If they are wasting at the hospital, at one of our hospitals, we have educated them all. Our pharmacy has requested that they all waste into a narcotic. It's like a sharps container, but it's made for narcotics. I don't know what the actual name is, but it's the same place that our nurses waste narcotics. But we have educated our paramedics to do it if they're wasting at the hospital, not to put it down in a trash can or a sink. We actually, with our Pyxuses, have a container for them to waste it in.
Perfect. Michael, if you wouldn't mind switching that to the next slide, and please, everyone, feel free to reach out to Michael. Just understand it may be a delay before he can respond to your questions based on his travel and his work schedule. But I wanted to also let you know that we have a wealth of helpful content available for on-demand viewing at our website. Simply grab the plugins menu and click on webinars to choose a session. I want to take a moment to give a special thank you to Michael for sharing all of this awesome information with us, and to all of you for attending. Michael, if you'll switch it to the final slide. Operative IQ is invested in our client success. These are the folks that would be happy to help you discuss your needs and provide you with more information about our services or assist you if you are a current client. You can schedule time directly with your regional account managers from our Contact Us page. We are so fortunate to have some incredible expert users willing to share their stories, and learning from our peers is so incredibly important and valuable. And this Client Success webinar series is produced with the intention of growing a community of Operative IQ users who can continue to help each other learn and grow within the community. Thank you again to our presenter, Michael Gilbert, and Memorial Hospital for his transparency and willingness to share his experience. And thank you so much again to all of our attendees for joining us today. Have a wonderful day.